Good afternoon/evening, everyone. My name is Shane Doyle from Implenet America, based here in Boston. Thank you for joining this webinar regarding proximal junctional kyphosis, prevalence, and prevention. We are excited and honored to have Dr. Virginie Lafage with us, as well as Dr. Elizabeth Lord with us. Dr. Lafage is the Associate VP of Clinical Research at Lenox Hill Hospital in Northwell Health in New York City. And Dr. Lord is the Assistant Professor of Orthopedic Surgery at UCLA in Los Angeles. We will start with Dr. Lafage giving us a little bit of the background and the prevalence of proximal junctional kyphosis and many of the clinical issues and parameters around PJK. And then Dr. Lord will take us through several case instances of mitigation strategies for proximal junctional kyphosis. So without further ado, Dr. Lafage, if you'd like to take it away.
Absolutely. Good evening or good afternoon, everybody. So my name is Virginie. As Shane mentioned, I'm working at Lenox Hill. My background, I'm a mechanical engineer, and so don't ask me any clinical question. I will redirect those questions to Dr. Lord. And I have a PhD in biomechanics. Despite my very strong French accent, I've been in New York for almost 20 years, and I focused like most of my career on clinical research in adult spinal deformity. So I'm going to give you the first part of the talk, which is basically a literature review of PJK and some of the either like big factor or small detail that when you consider them all together, they started to matter. So these are my disclosure, as well as the one from Renaud Lafage, or Lafage, as we say in the US. So today we're going to talk about PJK, but in the setting of adult spinal deformity. And when you come to adult spinal deformity, like the more you look for it, the more you're going to find some. In the sense that, getting the spine to collapse over time when we age, it's almost normal. It doesn't mean that we need a treatment, doesn't mean that we need surgery, but the spine evolves with age and sometimes develops some deformity. And we are in a world where the population is aging, so we're going to see more and more of those patients. Adult spinal deformity is actually quite complex because when you look at the spine, it can get deformed in any direction. So you can have a focal, regional, or global deformity, but it can be in the conal plane, the sagittal plane, the axial plane, and very often all of these get combined together. And we tend to spend a lot of time looking at the bone and looking at the alignment of the spine from a bony perspective. But those patients, they're on the older age, meaning that everything is affected. So we're not dealing with just a deformed healthy spine. We're dealing with a sick spine, and this affects like the ligament, this affects like the disc, the muscle. So there is already nothing normal anymore in this population. So what do we know? We know that above a certain level of disability, patient will benefit from surgery. And this is an old study from Dr. Bridwell. And if we look at the data today, we're going to have exactly the same result, in the sense that if the patient is disabled, they're more likely to benefit from surgery than from conservative care. But it does come at a cost, and the cost is complication. So whether it's pseudoarthrosis, affection, hardware failure, and one of those complications is PJK. So PJK, for proximal junctional kyphosis, is only a form of adjacent segment pathology. It's very common in this population. It affects like maybe 40 to 50% of the patient following a long fusion. It's an acute pathology. 2/3 of the PJK are going to be visible within the first 3 months. They may still progress, but at least you see them like very, very, very quickly. And in terms of definition, there is probably like 10 different definitions in the literature. There is a radiographic one where it's going to be like a small kyphosis of about 10 degrees. Most of the time, those small kyphosis are asymptomatic. They just don't look nice on the image. But there is a clinical one where we're talking more about like 25 degrees of kyphosis or a neurological impairment or some pain. That's the bad one, the one that we're afraid of. But PJK is not a single pathology because it comes in different shape and form. You can have a bone collapse. You can have a failure of the ligamentous complex, either associated with maybe too much dissection or too much loading on the soft tissue. You can have a failure at the interface between the implant and the bone, and really like it affects like the adult, but also we see that a little bit in the kids. So from a research point of view, like we are far from having the solution. But what I want to do today is to tell you about a few of the risk factors that has been recognized and sometimes accepted in the literature. So I'm going to talk about some of the patient factor, some of the alignment. You know, obviously that's my area of I wouldn't say expertise, but that's my data. And UAV selection and road contouring, and some prophylactic strategy. So let's talk about patient factor. Now, maybe like the most important one is the quality of the bone. And as a clinician, that's something like you monitor very closely. But what is a little bit sad is that as a researcher, we very often do not have access to this data. So you have a ton of publication on PJK, and very few of them have some information about the quality of the bone. And when you come to orthopedic practice, and more specifically spine surgery, 50% of the women over 50-year-old have some osteoporosis. So now we have two problems, because when we have poor bone quality, first, it can create a deformity, and second, it complicates the treatment. And so, as I say, like the literature is a little bit all over the place, but there is one thing that that has been confirmed in the few studies that talk about it, is that osteoporosis or poor bone quality is associated with implant failure, with screw pull-out, and with PJK. So in this study from Yagi, where they had like a 76 patient, less than half of the patient had a normal bone mineral density. 20% of the patient developed PJK, and low bone mineral density was one of the risk factors. If you're using DEXA to evaluate your patient, you know, we don't have a good number in mind about like what is a bad DEXA in terms of risk factor for PJK. And so more and more you're seeing some study where people are using a CT scan. You know, if you get a CT scan for your patient for a different reason, you can measure the Ausfall unit. So most of the PAC system will have a tool where you can draw an area of interest and measure the Ausfall unit of the vertebral body. If you want, you can also measure that of the pedicle. And when I was at HSS, we looked at our population of adult spinal deformity, and we measure the Ausfall unit at the future UIV and UIV +1. And then we look at our post-operative outcome. We have like three groups of patients. The lucky one that did not develop PJK. Then we had some soft tissue PJK and some bony PJK, which is basically a fracture of the vertebral body. And look at the table. The table here is going to give you the Ausfall unit of the three groups. So patients that develop a bony PJK, on average, the Ausfall unit was 109 versus 140 and almost 170 for the other one. And so we came up with a threshold, which is a Ausfall unit less than 120. And this is a risk factor for PJK with an odd ratio of 5.7. So a decent odd ratio. Beside the quality of the bone, you know, we are spending more and more time on looking at the frailty. So frailty is a way to evaluate the physiological age of the patient. We run a few studies with the ISLG and demonstrate that patients that are severely frail, they have an odd ratio of 3.1. So that means the risk of developing PJK is 3 times higher than if the patient are not frail. There's one aspect that we tend to forget, and that's because like we haven't done a lot of study on it, but it's starting to come up, is the quality of the muscle, and mainly like the erector spinae and the multifidus. As I mentioned previously, those patients, they have more than just a deformed spine. The degenerative process affect everything. And the few studies that are published in the literature on adult spinal deformity, PJK, and muscle quality tend to demonstrate that patients that develop a PJK, they have more fat infiltration in the erector spinae and the multifidus. So this kind of contribute to the stability of the spine. So we need to start to think about it. So the second part of the talk is about like a alignment aspect. And don't worry, I'm just going to focus on alignment versus PJK. So the thing with PJK is that if you run an analysis just on one parameter and you run over and over different analyses, you're going to realize that everything is a risk factor for PJK. Basically, like spine surgery is a risk factor. And from a global alignment, there is two types of patients that develop PJK. So you have the overcorrected patient, the one on the left here, where they have like too much lordosis, and the undercorrected patient, so a flattening of the lumbar lordosis. So these are like two different morphotypes. And I'm going to illustrate like the mechanism for those two types of patients. So let's start by the undercorrected, so the patients that are fused flat. And to understand what is going on, it's important to think about like the mass distribution. So the head is about like 4 kilograms, so 6% of the body mass. The trunk is about like 60% of the body mass. So if I have a patient that is undercorrected, like on this schematic representation, a flat lumbar lordosis, the trunk tilt forward, the mass of the upper segment, the unfused segment, is going to create a lever arm on the UIV. And slowly by slowly, we're going to enter in a vicious circle. So this bending moment is going to push the spine forward, the spine is going to collapse, the distance increase, and the bending moment increase. In the sense that if you have a sagittal malalignment in a fused spine, the weight of the upper body play in a very negative way on your junction. So that's one type of global alignment associated with PJK. The other type is the overcorrection. And it's actually very difficult to analyze an X-ray because a lot of people, me included, like we're using the SVA. So you drop a plumb line from C7, for example, and you look at this plumb line versus the pelvis. If I just look at the plumb line on this patient, I would say like, not bad at all. It's over the femoral head, just a little bit anterior to the sacrum. And so we need to understand what is going on. Obviously there is a huge PJK here. What I like to do when I see an X-ray or a patient with PJK, I like to try to imagine what will be the shape of the spine without the PJK. So I'm very fortunate because I'm not a surgeon. That means that I can take an image and cut the image and nobody's going to bleed. So that's what I did here. I remove the PJK and look at the alignment. And so basically, in the setting of overcorrection, we can think about PJK as a way for the patient to compensate, as a way to bring back the spine and bring back the head over the pelvis. And this is a very important phenomenon because if we overcorrect the patient, it doesn't matter what prophylactic technique we use, the patient is always going to try to come back. And so that's why, that's one of the applications of the age-adjusted alignment threshold that we published a few years ago. So those thresholds were derived based on clinical outcome. So they do not represent like the normative asymptomatic population. They represent a population of adult spinal deformity, how much they can tolerate. And we were a little bit lucky because when applying this threshold, we realized that it's actually a quite decent predictor of PJK or PJF. So what does it mean? It means that if we overcorrect our patient versus our threshold, then we put them at risk of developing a PJK and sometimes a PJF. So now we're at the point where we're like, okay, the global alignment matters. the amount of lordosis matters. And I want to add like one more criteria, which is the distribution of the lordosis. So this is an extreme case. If I look at the number, this is an average pelvic incidence, like 52, an average lordosis, those two numbers match. But look at the distribution. That the apex of the lordosis is at L2. And most of the lordosis is the proximal lumbar spine. What we're trying to achieve is exactly the other way around. We're trying to put more lordosis in the distal segment. And what we demonstrate in some of our publications is that it's not sufficient just to restore the lordosis to a given number. We also need to think about the distribution because this is an additional risk factor for PJK. The flexibility of the spine. So the flexibility of the spine can be your friend as a surgeon because maybe you won't have to do as many osteotomy as if the spine was stiff. But it can also be tricky because if you have a flexible thoracic kyphosis, in the sense that if the thoracic kyphosis flattens when the patient is in prone or supine position, then we increase the risk of PJK. And the possible explanation is that if we don't pay attention that the thoracic spine is flattening, then we're going to fuse the thoracic spine in a flat position. Flattening the thoracic spine brings the patient backward, and then the patient wants to come back. Okay, now let's talk about UAV and rod contouring. So we're all familiar with the general rule of how to select the UAV. So basically, like we don't want to fuse at the apex of the kyphosis. We want to avoid the transition zone. We want to take into account like the coronal plane because we want to end at the neutral vertebra. And if it's a patient with a thoracic scoliosis, basically we want to go high. But we probably need to go a little bit more deeper and take into account like the bone quality, the muscle quality, and the flexibility of the UAV zone. So talking about the UAV zone, there's two big types of surgery when it comes to adult spinal deformity: the lower thoracic to pelvis or the upper thoracic to pelvis. When it comes to lower thoracic to pelvis, we did a study where we looked at the orientation of the end of the construct. And you have a representation of the patient here on the left that did not develop PJK and one that developed PJK. And what we realized is that the way we contour the rod around the UAV seems to have an impact. So if we keep the rod straight in the setting of thoracolumbar fusion, then what we do indirectly is that we increase the length of the lordosis. So we bring the spine like backward. Now it's possible that the lordosis was perfect up to L1, maybe up to T12, but we didn't respect the correct orientation of the thoracolumbar junction. And then we found a very similar conclusion when it comes to long fusion. So for long fusion, again, like the contour of the rod at the proximal segment seems to have a somewhat of an impact on PJK. So if we keep the rod like too straight, those patients, then we increase the risk of those patients to develop PJK. So we can have like to initiate like the kyphotic angulation. Now I'm going to go very briefly about prophylactic strategy. And so why are we trying to have some prophylactic strategy? From a mechanical point of view, if you think about a fused spine, a fused instrumented spine, we're going to have something that is extremely stiff. And then above, we have the normal spine. And at the junction between the two, we have an increased range of motion. We have an increased stress. So this has been demonstrated by some finite element model. So we collectively, we're trying to create a gradient of stiffness. So instead of going from something that is super stiff to the spine, maybe we go from super stiff to a little bit less stiff until we transition nicely to the spine. And so there is actually a review that has been published in 2022. So I believe it was last summer, It's a review of the different prophylactic technique in the setting of PJK prevention. So, among one of the oldest technique would be like the vertebroplasty. There is about like 7 publications on the topic. It doesn't seem to have a huge impact on PJK. Other teams have tried to use a transverse process hook. They looked at PJF, so it may have an impact on PJK, but not on PJF. Then you have flexible rods, then you have like a multi-level stabilization screw. A ton of different techniques, but there is no strong study that make us believe like, listen, this technique works the best. And then there is everything that has to do with tether. So again, we are not at a point, and I'm so looking forward from the talk from Dr. Lord. But as of today, now if you talk to your colleague, like everybody that is using some tether, they're using maybe a different configuration. So you can have a tether that is attached to a connector. You can have a tether on 1 level, on 2 level, on 3 level. You can have a tether that just go from one vertebra to the other one. You can have a figure of 8. I would say there is probably as many configurations that we have publication, or the other way around, which means that we're still looking for the optimal configuration. In terms of tether type, in the literature, people have reported like the use of commercial tether, Merceline tape, or sometimes some allograft. Again, from a biomechanical point of view, if you look at like what has been published using fine entailment model or in vitro experiment, the objective is to control the range of motion at the level adjacent to the fusion. So you don't want to have something that do not move and then everything is concentrated at the junction. So control the range of fusion, but also control the load. And I would say today we probably need to think about like a well-designed prospective study. Like once we're confident that we may have a solution that is reproducible, we're going to have to do like a prospective study and maybe a randomized trial. So in conclusion, when you come to PJK, you can see like there is so many risk factors from a patient point of view, from a global, regional alignment, focal alignment. Unfortunately, there is no magic solution. So it's not like you can use like one of those concepts and get away without any PJK. It's probably combining those concepts. And that's what makes it like interesting, but quite challenging. Thank you very much.
Thank you very much, Dr. Lafage. That was a very informative presentation.
All right, excellent. That's such a great presentation, Dr. Lafage. It's always such a treat to hear you present and see your amazing PowerPoints. And I am looking forward to your feedback because I have some questions for you as well on what I've done. So I'm an adult spinal deformity surgeon here at UCLA. I did my training at NYU, and so these are some of those techniques, many of which Dr. Lafage has already described that I use. And I'm just going to run through some cases where I've used these techniques and how they have and have not worked. So this first case is a severe lumbar dislocation, which I ended up treating with an L4 anterior and posterior VCR, and ended up doing a T3 to sacrum, posterior spinal fusion, and then I did use the tether up to T2. The background in her, she's a 65-year-old woman who had a history of a T10 to pelvis posterior spinal fusion back in 2008, when frankly, the understanding of sagittal alignment was not quite where it was. So she'd had several recent falls, most recently into a ditch, and sorry, that should say April 2022. Unable to stand or sit upright ever since. She felt an explosion in her back at the time, and had recent bilateral leg numbness, tingling, pain in her legs, severe back pain, and at this point forward had to ambulate with a walker. She did have history of anxiety, but was generally healthy other than the fact that she was a half-day smoker for 45 years and lived alone with the dog, so minimal social support. Her in clinic, she had a very abnormal gait. She was stooped over approximately 90 degrees, not able to heel toe walk or tandem gait, very tender, although her incision was still intact, nothing was poking through the incision. And she's kind of diffusely weak all over, just poor effort. Here are her x-rays. Again, she could stand, but the middle is her standing film. So you can see the angle roughly that she's able to, that's her full upright effort at the time that I saw her. On the left is her sitting, so that she could kind of use her muscles to get herself a little bit more back in the seated position. And then you've got the lateral there seated, so you can quite clearly see the rod fracture there between the 4-5 interface. So interestingly, she actually had been seen, not by myself, but at sort of somewhere regionally where I was able to get her previous x-rays. And this is what her initial construct looked like. So you can see that her lumbar lordosis is 34. So it didn't, I mean, I couldn't see her PI at this point, and neither could they, which they should have, but essentially doesn't look like it matches her average PI. And, you know, obviously the apex is sort of higher than maybe ideal, around 2-3. And then as she was sort of making her way to me, she did see a couple other surgeons prior to kind of finding me. This is sort of the first shot she had when she initially broke. And you can see at this point, lumbar lordosis is down to 12, and she's just a little bit pitched forward, but not severe at this point. The MRI that she obtained at the time did demonstrate, you know, the fracture there. And at this point, not severe stenosis, but importantly, she's got these strange psoas, you know, kind of this transitional anatomy. And so again, as she kind of is going on, you can see now, because she started to lean forward, and as Dr. Lafage has pointed out, her center of mass is more forward. Now she's also developed a PJK above the construct, which she did not have previously. And again, that's, I think, due to her being more forward now than she had been previously. Here's a CT. Again, all of this sort of obtained before I got to her. So finally, I see her in August, and this is where she's at. At this point, she can't really sit up. She can't lie supine. So again, worsening fracture there. So I do use one of my PJF prevention strategies is using careful attention to the alignment and careful planning in these custom rods. I do think they take into account the lordosis distribution. It really helps you figure out where you are rather than being on the table and trying to like decide then. And then it also helps build in that proximal, the proximal angle essentially to be confluent with the spine and not at a difficult angle. So this is my plan for her. And we were able to achieve, this is the posterior part on the table. So I think we got, you know, a nice correction there with the posterior correction. And you can, this is before I put the tether on because the tether has some radiographs, but essentially I did want to tether her up. I especially worry on these constructs to the upper thoracic spine that you're going to have that catastrophic ligamentous failure that Dr. Lafage indicated. And so, you know, I'll use different cement or the tether or potentially both, depending on how concerned I am about bone quality. But in her case, in spite of the fact that she was a smoker, I felt like the alignment was good enough. I didn't necessarily need to do cement, but I did very much so want to do a tether at the top to prevent that catastrophic ligamentous failure. And then I just went in the front and kind of filled it in with the front with some tricortical allograft. And so here she is, about 2 months post-op, still up there. You can now see the tether, which is these, I'll take a pointer on here. There's a beneath UIV and UIV -1, there's an extra metal kind of outrigger there, and that's the attachment point from the tether to the rod. And it looks like she kind of fell forward a little bit between 2 and 6 months post-op, but when you measure the angle, it's about 5 degrees. So, you know, not quite even in the PJK, much less PJF. So I've been struggling to get her to follow up, but so far I think it's a good result. She's not complaining of pain back there. Next patient is an adult spinal deformity who had both coronal and sagittal malalignment. So I treated, again, T4 to pelvis with the tether up to T3. This guy's interesting. He had a brachial plexus injury as a child, so his right arm had some wasting, and also had a history of prostate cancer. And he had this kind of rapid development of this quite like neuromuscular looking degenerative scoliosis after the treatment for his prostate cancer, including radiation to his spine. So it's sort of unclear the mechanism behind that, but he was only able to ambulate about 30 feet with a walker before he needed a break. Again, right arm wasting, but otherwise 5 out of 5. So he had this, you know, kind of significant coronal shift, and then also, you know, a slight sagittal imbalance, but primary coronal issue here. But again, even though it's primarily a coronal issue, you need to be sure, again, for PJF and PJK prevention purposes, to pay attention to the sagittal profile. So, you know, I did that again with the preoperative planning to get get him where I wanted him to be. And again, kind of to Dr. Lafage's point about the SVA not always giving you what you want, I also use the TPA, and my goal is typically less than 20 or 19 in order to get people where they are. And that is sort of takes some of the sagittal kind of the pure distance out of the equation, because you can look at the angle from the posterior sacrum to the pelvic heads and get another sense of where things are without the leg compensation. So again, looking at his CT here, you can see he's really quite flexible. He doesn't have any bridging osteophytes. He didn't have any autofusion. He does have the residual from his prostate cancer mets in the spine, but at this point it had totally burnt out. And for all of my patients, again, another PJF and PJK prevention strategy I use is obtaining, in addition to the Hounsfield unit, obtaining a DEXA scan. And the DEXA scan is really, even if you're going to do the Hounsfield units, if you want to get approval for any of the anabolic agents, which is what I put my patients on preoperatively, who have osteoporosis, you really do need a DEXA to kind of get them in the door for the pre-approval process for that. So he did not have that issue, so I didn't need to worry about that with him. So I started off with A-lifts here to sort of get those, the L4-5 and 5-1 more horizontal, and also provide a nice foundation for fusion. And we got a pretty good correction here, again, because he was so flexible. On this one, you can see the tethers there. I put them below UIV here. Again, like Dr. Lafage, I don't necessarily have like a pure, I'll show you my technique at the end, but at this point I was still sort of working out what worked best for me in terms of where to anchor things. So 1 year post-op, he has, not fallen off at all, even with this quite long construct and the pretty significant correction here. And he really has had, virtually no change there in his ankle. So he's quite happy, and I'm happy with that. Kind of the perfect patient with those mets actually making his bone density probably a little bit harder than without them. Final case, this is adult Jen Scully treated with T-dent to pelvis. I did tether her, however, that was not the be-all end-all. She PJF'd, and so I extended her up. So initially when I saw her, she had this lower back pain and a progressive deformity for about 10 years, and it was finally getting to the point that she just couldn't do her activities of daily living, going to work due to this back pain. She had a clear shift visibly, but was 5 out of 5 everywhere, with some small balance issues. So here are her x-rays. You can see she's got this, very classic sort of degen scoliosis type picture with the deformity really focused in that lumbar spine, which tends to go quicker without the ribs there. Not a ton of rotation. And then the sort of change in her, let's say hyperlordosis underneath, and then the sort of change of her where the apex is, and this kind of flattening, this hypokyphosis of her thoracic spine, presumably sort of compensating for the hyperlordosis down beneath in her lumbar spine which is part of her deformity. And then looking at her DEXA scan, she did have osteoporosis, pretty real, in a lot of places. So I did put her on, or I sent her to endocrinology, who did put her on an anabolic agent for 3 months. At the time, I was not getting repeat CTs essentially preoperatively to recheck Hounsfield units. I've since learned that there's about a 10% non-responder rate to these anabolic agents. And so my practice now is to put them on the agent, book them for like 4 months out, 5 months out, but get a repeat CT over a month out from surgery to actually see if they've had a response to the anabolic agent. And then if they haven't, potentially change my strategy or my UIV. And if they have responded, it's all good. Initially, I wanted to stop short here because I felt like the deformity was primarily in her lumbar spine and not really in her thoracic spine. Due to her bone density issues, I was worried. And again, she didn't have a huge coronal or huge sagittal issue, so I wanted to just do some T-lifts instead of A-lifts, which I normally do if I need to get them back sagittally. I used the cement augmentation here in addition to the tether because I was worried about her bone density. As you can see, I just did the UIV and UIV -1, which would essentially protect for screw pullout, but obviously I'm not protecting the bone above. And I did do a tether again for ligamentous prevention, even though this is the lower thoracic spine. And not unpredictably, she's overcorrected, I would say. even in spite of the fact I again used custom rods. But she did have a fracture there at UIV +1, which you can see quite clearly at the T9 there. You know, this ended up, even though I don't feel like this was truly her apex, initially I thought that hypokyphosis would sort of shake out and she would, you know, change her alignment. It is overcorrected, and then I sort of made it the apex of her kyphosis, which is a no-no, so she fractured. And here's a CT scan showing, you know, real kind of vertebra plana there. And also just you can look at the bones and see she has compression fracture above. She has that really kind of jailhouse bar vertebral body look. So, you know, quite bad bone quality. And this is intra-op. When I went back to look at this, that's what the tether looked like. At the time I was doing essentially just a straight up and down loop through the UIV +1. And you can see how, you know, this didn't fail. It was still intact. It was still connected there, but it was quite loose because, you know, obviously at this point, the height of the anterior column was much shorter. So this wasn't under tension anymore, and it wasn't really doing much at that point. So then I took her up and went to T2. I measured her Hounsfield units in her upper thoracic spine, and T2 looked more favorable than T3 or T4. So that's where I went, did a tether again, extended her up. I've gotten out of augmenting the upper thoracic spine just because I feel like the visualization isn't quite there. And I've also had basically a number of issues of cement extruding and going, in one case, into the pulmonary artery and causing a large embolus. So I think I'm going to limit that to the lower thoracic spine and just do the tethers at the top. And so she continues to do well. She has not PJF'd here. She's now over 6 months out, so we're out of the kind of early period for that. So, you know, this is really what I'm doing in all of my deformities now, all of my adult spinal deformities. The technique that I like to use, you know, although I agree, I don't think we know for sure which is the best or if there is a best, but I do like to do things in a standardized fashion and do it the same way every way, is this weaving technique through UIV +1, UIV, and UIV -1, which is described in this paper here. And essentially it's this, it's the weaving, UIV, UIV -1, and UIV, and attaching it to the rod using these little metal devices. Sometimes I've been due to like a satellite rod next to it, I've been unable to get the connector on, in which case I just tie it on, because again, it doesn't have to be like crazy tight. One issue that I found is that, again, I'm really trying to protect the soft tissues in the midline when I'm doing my UIV work and UIV regional work. And so I don't necessarily want to be, you know, peeling all of the bone off UIV -1 or UIV +1. So rather what I do is I do sort of a paramedian just to find the, you know, the facets and the start point for the screws. And so midline, I have a lot of soft tissue there. So I found, you know, the technique that's typically described is going through with a burr and then sort of just passing the tether through. That doesn't work well for me because I frankly have a lot more soft tissue left up there than is shown in this picture. So what I do is I do the burr back and forth, but then I use this suture passer. This is something that any ortho, you know, hospital is going to have. They use this for, I think, I don't know, ACLs or, you know, some maybe rotator cuff, something like that. And so basically this can find that hole a lot easier. And then you just put this thing through the hole, put the tether through it, and then pull it out the other side. And that's much, much easier than trying to take this tether, which is, it's like it's threading a needle with a needleless, you know, a needle helper versus trying to take a thread and put it through the eye of the needle. So this would be my kind of my #1 tip for doing these cases. Yeah.
Thank you very much, Dr. Lord. That was very informative, seeing both some index cases and some revision cases as well.
And those are complex cases that you're tackling.
Yeah, yes.
Yeah.
Yes.
Very much so. Dr. Lord, can you speak a little bit to, you know, you illustrated some tether cases here. Can you illustrate or discuss a little bit about how your prevention strategies have kind of evolved over time? I know you showed some cement in the first UIV and UIV -1 screws. Have you had vertebroplasty experience, or kind of what's your evolution?
Yes. So initially, I was really leaning heavily on the vertebroplasty. really to prevent the screw pull out, or I would just say cement augmentation through the screw head. And then I started doing more vertebroplasty at UIV +1 and even +2 sometimes. At this point, but again, it's difficult to get the cement in there. The cement extrudes a lot. I think a lot more than people discuss. And I've had an issue with the cement not going out directly. I didn't spear the pulmonary artery, but it goes out the segmentals essentially and the veins and goes into the pulmonary artery. And then a patient had a large thrombus. And then you have to anticoagulate someone on post-op day 1 from a T4 to pelvis. Not ideal. So I've started really just doing the vertebroplasties in the lower thoracic spine, which has the most sort of bony failures, and really only in patients where I do feel like they haven't responded to the anabolic agents or the Hounsfield unit's not quite where I need it to be or some other extra thing. And I wasn't using the tethers initially. I'm now using the tethers both in lower thoracic UIV and upper thoracic UIV, and I haven't had too many cervical deformities, but frankly, I would also use it for DJK prevention as well if that were to come up. I do feel like the weaving technique, UIV -1 and +1 it does feel like it's sort of this transition. And I'm not sure if you saw in my rods, I do multi-rod constructs. I do tend to try to change to not have like a cutoff, to not have a one spot where we're ending both rods on the same side, but rather distribute the distribution of forces essentially. So it's not a soft landing, just having 2 rods at the top, but it's softer than having, all 4. And then the custom rods, I think are potentially the most useful, just getting that alignment right the first time. And then the soft tissue protection. Like I said, not doing a huge midline dissection at the UIV region, but rather going out slightly off and maintaining all the midline soft tissues.
Yeah, and I think what I like, one of the comments that you made during your talk is the patient that had two surgery with a collapse at the UIV after the first surgery. Mm-hmm. So I believe I think we probably need a better understanding of the risk factor associated with each mode of failure. Because as you mentioned, for example, if you put a posterior tether, the objective of the tether is to create a gradient of stiffness, but really the mode of action is to prevent a PJK, and mainly a soft tissue PJK. Mm-hmm. The support tether cannot do anything against a collapse of the bone. So we have to be careful, in the sense that some technology are probably going to help us with certain mode of failure, but probably not with every single mode of junctional failure.
Right. So would the vertebroplasty have prevented that? Probably not. She was still too posterior. The alignment wasn't right.
Dr. Lord, you brought up another question that we've had from the audience, and maybe Dr. Lafage, you could also comment on this from the literature perspective. Is DJK in cervical thoracic deformity and surgery as well? It seems to be something that we hear more and more of, and we're starting to see more and more in the literature as well.
Yes.
Good.
I'll say I was going to defer to you. It's not been cervical deformity is not a huge part of my practice, so I would say I would bounce that to Dr. Lafage, who I'm sure has more experience.
Yeah. So whether in setting of cervical deformity or in the setting, let's say on Scheuermann patient, this is a problem as big as PJK. The only reason why we talk less about PJK is because cervical deformity is not as common as adult spinal deformity. But it's actually more challenging to study and to understand DJK than PJK, because with DJK, you're dealing with a floating fusion, unless your patient is extended to the occiput, which is, we hope that is very, very, very rare. So you need to understand how the spine is going to react above the fusion and below the fusion. So it's a more challenging mechanism to understand. But a few people have started to put some tether, as you mentioned, Dr. Lord, also in the setting of of DJK. We just don't have like the sufficient number to draw any conclusion right now. But the mechanisms are very similar, just more complex to grasp and come up with some clean risk factor because everything moves above and below.
Thank you very much. The majority of the questions that I had throughout the presentation, you've actually answered as we've gone along here in the discussion. I don't know if either of you have any other questions for one another that you think would be relevant to the discussion here, or
yeah. So I do have one for Dr. Lod. Is about like your management of your pre-op management for the bone quality. What do you put your patient on? How long do you leave them on? And what do you do to check? You mentioned like one specific patient where you did a repeat CT scan. I know that with DEXA there is an authorization issue, but what is your protocol right now, and what would be your ideal protocol if we did not have to get like insurance authorization?
So very good questions. So at this point, I'm definitely getting DEXAs on everyone. In terms of the CT scan, I think it's most valuable preoperatively, and I don't love to irradiate my patients, especially because many of my patients now are kind of younger and they're like 40s and 50s. So I'll get the DEXA first. If they're just osteopenic or osteoporotic, either way, I'll send them to endocrinology. And if they're osteoporotic, I certainly, no matter what, fight the insurance. They have to go on anabolic agent for 3 months is what I've been doing. One issue is I have a number of cancer survivors, essentially, and apparently these anabolic agents are contraindicated. They can go on denosumab, and we're actually going to be doing a study to see it's not as good, but essentially how not as good in terms of the response there. So that's sort of the middle ground, but it's not my preference. And then what I'm starting to do now is waiting until we're about a month pre-op, and after they've been on the agents for 2.5, 3 months to see that they've responded, and really not kind of selecting my UIV or pulling the trigger until then. At this point, the few that I've done, I think I've only done like 3 since I've started doing that. They've all responded. But again, what I've heard kind of anecdotally it was Dr. Shaffrey actually who told me that about 10% of people don't respond, and to really check and make sure that if they haven't responded, again, I'm not totally sure what I do differently. Maybe just really carefully scrutinize UIV, add the cement in that case.
And another question I have for you is like for your tether technique, and mainly in setting of thoracolumbar fusion down to pelvis. Do you ever go more than 1 level above UIV, or your protocol is?
Yeah, I initially did. Again, I didn't have anything to base that on. I just didn't sort of know what to do, like many people. And then just sort of in discussing it, it was a conversation with Chris Ames, who wrote that paper, and he tried many things. And I think UIV +1 is a good compromise, purely in terms of soft tissue dissection, because you already have it just by getting the pedicles of UIV. You would definitely have to expose more to get to UIV +2. And that's sort of a trade-off that I don't know if it's worth it right now. Yeah.
I think maybe at one point we need to all meet, like all the people that are talking about the tether, and compare the technique and share our knowledge, because I feel like everybody's trying on their own, but if we were able like to all work together to compare the technique. So as you know, I work with Frank Schwab. He has been started like doing like UIV +1, and slowly by slowly like going like UIV +2, +3, just to see more around this concept of combining like PGK prophylactic and also ligament augmentation, because like the spine is sick, like the ligament are maybe not what they used to be, and the muscle, you have the fat infiltration. So can we think about the tether a little bit further than specifically like looking at the prophylactic aspect, but holding the spine, like you will put like on a boat, like you will have like a bunch of rope like to maintain everything. So, but that's just the beginning. So it's more like right now I bring more question than answer, to be honest.
Well, I'd like to, I want to be respectful of everybody's time here this evening, and I want to thank Dr. Lafage and Dr. Lord for this very informative discussion and Q&A session at the end of the talk. So thank you very much to both of you, and look forward to working with you both in the future.
Likewise. Thank you.
Thank you.